Can you get the cannabis from, I know you can't get it from your GP, so does it have to be from a consultant?
No, a GP can do it. The question is whether they will do it. So any doctor can do it. They don't make it easy. That's the first thing for me to say. So because of the kind of hurdles of being able to actually prescribe an illicit substance, it's not easy. So any doctor can do it. It would be for a specific patient for a specific drug.
Yeah, for me.
But the question is will they? And I think unfortunately, most of us doctors don't tend to go down that route. There is a New South Wales medicinal cannabis advisory group, which is helpful for clinicians unaware of the program to call up and ask, can I give my patient this for this? One of the things that tells people is that, look, yes, we think cannabis might be useful for nausea, but it's not cannabis instead of all the other anti-nausea drugs that we have. The studies looking at cannabis as an anti-nausea agent, look, it's effective, but it's using very, very old drugs, and we've got much better drugs now. So that scheme is basically to advise the GP saying, the patient wants it for nausea. Well, what are they on? Well, if they're not taking this, this, and this, then ask them to do that first, if that makes sense. Does it?
Yeah, thank you.
We've just got the next question here.
This is for James. I've mentioned to you about a very old alternative doctor from Sydney gave me some apricot kernels. Well, this leads into the Dr. Google thing because there's all this information about people taking apricot kernels to cure cancer, and he gave them to me, and he was from the Royal North Shore Hospital. He was like the head surgeon down there, and he's gone bush and lives off the grid and everything now, and he's in his 80s, and he was a very leading surgeon, and I researched it because I know I'm not just going to take something like that, and I looked into it, and when the body processes it actually turns into cyanide, and I've worked in laboratories before with cyanide, so I know that I'm not going to put cyanide into my body because that's not going to be very good for me, and people have all of these anecdotal evidence that it cured cancer and all of this stuff, but from my opinion, I wouldn't recommend it, and when I talked to you about it, you also said I wouldn't recommend that.
Yeah, it's a valid point. First thing I say is we work very closely with our colleagues, the surgeons, the radiation doctors. I know certain colleagues that recommend my treatments when they're not in the position to recommend them. And that you have to just be mindful of where your information is coming from.
Hi, it's just about the dexamethasone. I just missed the last bit on when you're weaning off from symptoms to go down. Yeah. So my husband's got some ptosis of his eyes, which is starting to obscure his vision. It is his only symptom, so we were really reluctant to go back onto Dex because he did have the very strong side effects of weak legs, etc., etc. So we've kind of postponed it. He's been on it for 5 days, just 4 milligrams. That was what the oncologist recommended. It has helped slightly. So when you wean off then, and if we come off, he's just likely to get the symptoms back.
Unfortunately, yes. I mean, everything we did give is a balance of risks and benefits. But the question is are the long-term risks worth the benefit of the improvement in his ptosis? What we can find is that sometimes the benefits are very much worth the risk. And in those sort of situations, what we try and do is, like I said, you just wean down to the dose where you think, okay, this is how well I want to be, and we'll see what sort of side effects we run into long term. The concentrations of the dexamethasone are a 4 milligram tablet and a 500 microgram tablet, so 1/8 the concentration of the 400 milligram. When I'm weaning down, I tend to go 4, 2, and then I start playing around with the 500 microgram tablets.
And stay on it, or?
That's a judgment call, which I would recommend you guys talk to your consultant about. Yeah. I mean, if it was just the ptosis, if the ptosis is having a dramatic effect on your quality of life, and you want to minimize that, then you stay on it. If you can live with the ptosis, then I would get off of it, because you're going to find it more difficult to live with the muscle weakness.
Yeah. Just because it's such an early side effect with nothing else, we're just worried about the length of time he might be on it. So it's a joke.
This is an ongoing conversation that I tend to have with my patients all the time. And there's no right answer. And it's usually an experiment as to what you guys works best for you.
Well, so is there a minimum dose that will have basically no side effects? I think last time you said on 2 milligrams a day you get very few side effects. Is that the case? Or long term, I would imagine you would still be getting...
Long term, it will cause problems.
Yeah.
The question is you much more, that long term will be lengthened the lower the dose you're on.
Yeah. And long term is what? So in a few months, or?
Everyone's different.
Yeah.
That's the other problem.
All right, thank you.
I just wanted to ask Michael, this new type of radiation that you're talking about, is it able to be done in the same site if you've had the regular type radiation? Because I've been told that once you've had it once, you can't have radiation in that spot anymore because of the damage to the area surrounding that. Is that something that will,
That's a really good question, and we're thinking that that's becoming less of a problem. So just to backtrack a little bit, the treatment's changed a lot over 20 years. And 20 years ago, when you were blasting through with just a few beams, then, they were probably right. You couldn't do it again. But as you get more conformal and keep the high-dose area pretty tightly just to the tumour, then it is sometimes possible to do treatments again, and people are starting to do that more and more. But what we're hoping with this intravenously given radiation, that it certainly gives us another option when people have already had radiation. Because it's usually where the beam's gone through before, the normal tissue, that's the problem. But we know that the radiation dose is forgotten over time, and they think that about 50% of the radiation dose gets forgotten every year. So the longer you go from your first treatment, that there is the possibility of retreating. But certainly the intravenous radiation technique is being looked at initially in people who've already had treatment.
Okay, thank you.
Hi, I've got a question for Michael. I've had a GBM grade 4 years ago and had combination therapy with oral chemo and linear radiation. Now my thing is, I'm clear now, and I just wanted to know my memory and my fatigue, is that a side effect from that radiation? Because and if I'm not making sense now, this is what happens with me and why I couldn't go back to nursing, because of my memory.
Yeah, look, it's tricky. So just with the tiredness first, the tiredness with radiation tends to be mostly at the time of radiation and for a month to 6 weeks afterwards. But, if you talk to patients carefully, it often goes on for 3-6 months after just radiation. The complicating thing is there's a whole lot of other things going on with chemotherapy, effects of the temozolomide on bone marrow and anemia and all these sort of things, and that makes it all a bit complicated. With the memory, it depends really what part of the brain's been irradiated. And we know
temporal lobe.
What's that?
Right temporal lobe and a bit of the hippocampus.
Right, yeah. So that's the problem. The hippocampus is the most sensitive part of the brain, and we know that even a dose of 2 to 8 Gray can start to cause damage to the hippocampus. When we're treating the tumour, we need to give 60 Gray. So you can see that it's quite easy to cause a highish dose to the hippocampus. There is evidence that things do improve over time, and the other thing people are looking at are chemicals that we can give to protect the brain while you go through radiation. But all of that work is fairly early stage.
Yeah. Okay. And Dr. Lynham, I've got non-genetic GBM. Now, is it true that I may not be, if it came back, eventually I wouldn't be able to go on trials because of that, if it's non-genetic?
So just to kind of deal with the definition of genetic, there's genetic, which implies running down in families, which brain tumors don't tend to do. Then there's genetic mutations within an individual's tumor, which might predict for sensitivity or resistance to certain drugs. Every tumor is genetic. It's about finding the right genetics within that tumor and having a drug available to address that. Trials are always an option and always worth asking about. Whether you'd be eligible for something that's available at that moment in time is impossible to predict. And that's the problem. When Craig put up the kind of list of these are the inclusions, these are the exclusions, they're very specific. And the reason behind that is making sure that we're not actually doing a disservice to people. The main purpose behind a trial is make sure we don't actually disadvantage a patient. And the reason that list is so long is so we make sure that we're actually giving the drug to the right people and not giving the drug to the wrong people who are actually not going to benefit and might actually run into significant problems.
My oncologist said I wouldn't even qualify at the moment, so...
There's not that much going on at the moment. I would say this, though, and this is a conversation I had this is something I mentioned last year. Trials have changed within the brain tumor sphere. Early phase trials, so the phase 1s that Craig talked about, they used to, 3 years ago, they would exclude anyone with a brain tumor. So if you had a brain tumor, you were not eligible for those newer trials. That's changed dramatically over this period of time. And increasingly, we're getting trials that are open and actually actively seeking people with brain tumors. They're a bit hard to find, but most of the oncologists are getting kind of savvy about ways of actually finding them.
Okay. Rightio. Thank you very much.
Hi, Dr. Fay. I just wanted to ask about proton therapy. I'm thinking about taking my daughter to Boston Hospital for proton, and just wondering, do you think it's a safer radiation?
Yeah, look, that's a really good question, and you're probably aware that Australia is developing a proton centre in Adelaide, but it won't be ready for a couple of years at least.
Yeah.
So the thing with protons is it's still radiation. It has the advantage of, instead of being a whole lot of different energies of radiation, the energy's all at the same sort of frequency, if you like, and so you can deposit the energy very, very precisely. There are a few brain tumours for which protons have been shown to be better than other things, particularly in children with tumours around the optic chiasm, where the eyes cross over, where the nerves from the eyes cross over. And the reason is that you can get a very sharp line between tumour and no tumour and radiation and no radiation. So from that point of view, you know, it can be helpful. The Americans were looking at ways of increasing, you know, the proton usage, if you like, and so they started doing some work with prostate cancer, and that's been fairly overhyped, I think, and so protons are being used also for prostates and things where it's probably not necessary. So I think for the few indications where you need to have a really tight demarcation between no treatment and treatment, certainly can be useful, but it's not, you know, magically able to do things that other forms of radiation can't do. It just decreases the side effects in some patients. But Boston's a great place. I worked in Mass General for a while, and it's a fantastic hospital.
Okay, thank you.
What's the relationship between the grade of the tumour and the effectiveness of the intervention on that tumour?
Sorry. So from a radiation point of view, the grade of the tumour really affects how quickly the tumour's growing, and the problem for us really is resistance and how quickly that develops. So we think that most of the recurrences that we see in glioblastoma, for instance, are from the tumour cycling very quickly and then developing more genetic abnormalities, some of which then make it very hard to treat the patient. Patients with low-grade tumours have long survival because the cancers are growing slowly and you've got time to cycle through different treatments, and you can throw in chemotherapy, you know, sometimes targeted treatments, not so much in brain tumours, and radiation. But the higher grade tumours tend to become resistant more quickly.
from a systemic therapy point of view, so from a chemotherapy point of view, the grade of the tumor can determine what combinations we use. Is that because, and putting things in example, low-grade tumors, we tend to use a 3-drug combination because that's what was shown to be effective in the studies. Most people with high-grade tumors get temozolomide now. There's increasing question as to whether the 3-drug combination is as effective as temozolomide, and that's being looked at in trials as we speak. I think the grade of the tumor probably determines how much you give and what you give at that point in time. I'm not sure if that answers your question, though.
Thank you.
Any other questions?
Yes. What's the half-life, or how long does it last, of temozolomide?
Oh, now you're asking. That's a really difficult question to answer because temozolomide is rapidly metabolized into the active drug, which we actually can't really measure very well. So I actually can't answer that question at the moment.
5 days of it.
Hmm.
How long is it going to continue working?
Well, so the relationship between how we give it and the dose we give it and how long we give that dose was determined based on 2 factors. One, how effective the temodol was on cancers preclinically, and 2, what sort of effect it had on people. So our usual dosing of 5 days every month is mainly to make well, it still works.
I'm on the second cycle.
Yeah, so the reason we do that is because sometimes we actually find that it takes the month for the temozolomide side effects to settle down, most importantly from its effect on the bone marrow.
Yeah.
We can actually give it, and I know several people in this room who are actually on a more long cycle where you'd actually take it for a much lower dose for 14 days every month. Now, there's anecdotal evidence that one way of giving it might be better than another way of giving it in certain situations with certain cancers, but that's still a evolving evidence base. You're not getting underdosed by only taking it 5 days. I would say that if you were to take that dose at that dose for longer than 5 days, you'd be running into serious problems.
Yeah, no, I took it for 5 days, and then nothing for
23.
that was days 1 to 5, and day 6 till 28, and then a blood test, and then I see the oncologist. Yeah.
James and I are actually doing a study at the moment trying to understand that a bit better. So we're doing serial blood tests, and the sort of processes inside your body that are going on are not really well understood at the moment. So I think it's a really good study.
Dr. Fay, the radiation that you were talking about, where you're using PET scans as well, is more targeted because you're getting a better picture from the PET scans. But did you say you're using IV therapy as well, did you say?
Yes, so the PET scan has a different molecule on the back of it. So it has the same joining molecule, if you like, to join to the tumour. So what we think, what we know will happen is if the PET scan shows that there's uptake, then if we give the therapy molecule, then you should have uptake in the same place.
Okay. And so for re-irradiation, is there a best time to do it, and who makes that decision? So we're in Coffs Harbour. I think they do have a new PET scan there. So yeah, what stage do you consider re-irradiation, and is that something we should be approaching our oncologist about, or? So
just dividing things up a little bit, the new sort of intravenous therapy that I'm talking about is really only done in a few centres in Australia at the moment. That tends to be large, treatment centres, and would only be on a clinical trial at the moment for brain tumours. Re-irradiation using standard radiation treatment can be done anywhere they do normal radiotherapy. What I do is suggest that when patients have done really well with radiation, so they look like they've got disease that responds to radiation, and also when they've had a long, what's called disease-free interval, so time from primary treatment to considering reirradiation. If that's a long time,
What's long?
many months or over a year.
Yeah.
Then I think those patients have got a higher chance of responding, and so the balance of side effects to benefit is in favour of treatment. But it really needs to be individualised. You really need to discuss each patient. And I wouldn't make that decision alone. We'd all talk about it and think about what the options were.
Yeah, so we are in a little bit more remote, so we don't have, obviously, the benefit of having the oncologists that deal in brain cancer as such. So, yeah, just looking at a time frame. So is it when it starts growing again and other therapies are not working anymore, which is the stage that we're at where it's still small, no side effects? Is this a good time to consider re-irradiation? And
you really need to take all the factors into account. But yeah, if it's been a long time, if it's an area that's not going to cause a huge amount of problem, if you irradiate again, so it depends on the part of the brain, and then a discussion with your oncologist. But look, we talk with the guys from COFs and up the coast quite frequently, so there's no problem there.
okay, all right. And sorry, can I have another very quick question? Dr. Lyon, sorry. Have you seen much benefit from the use of lomustine? Are you using that?
So lomustine is our go-to drug in the second-line setting. So once Temodol stops working, we use lomustine. The evidence for it is lacking. So with Temodol, we know it works because we did a study with Temodol versus nothing, and Temodol was better. With lomustine, there are no studies like that. We tried lomustine, and this is how long people lived. I do try it, and it certainly helped some of my patients. Some of my patients who rapidly progressed on temozolomide had long disease stability on lomustine. But it's very much a kind of, let's give it a go and see what happens, but with the understanding that I would stop it if I was worried we were running into problems. And the main problem with lomustine, again, is nausea, but also its effect on the bone marrow.
With the PET scan you were talking about, if you've had a tumour removed from your brain, even though you can be the highest grade still, there'd be no need to have a PET scan at all, would there? You just do your MRIs every 3 months.
That's a really good question. The trouble has been that we haven't had very wide availability of these PET scans. So when we talk about a PET scan, normally we're using a chemical called FDG, which is basically a type of glucose. And the trouble in the brain is that all of the brain uses glucose, so it all lights up, and you can't tell which bit's more active very, very easily. So you have to use a different kind of chemical. Currently, we don't have any ability to make those chemicals in the hunter, so they have to come in from somewhere else. The half-life of most of these things is 2 hours, so half of it's gone after 2 hours. So they need to be flown up from Melbourne and made in large quantity. And so we're only really getting to the point where we've got that technology now. And then it's a question of which patients are going to benefit from having this intervention. You're absolutely right. If the MRI is looking stable, you had the tumour removed, you had all the treatment, everything's stable, I wouldn't be suggesting that we do any sort of imaging. But I guess it's the patients where we're not sure. The MRI might look like it's different. We're thinking about whether they need more surgery or perhaps more radiation. Then it can be helpful answering that question. And we're also looking at the question of whether the PET scan can help us plan the radiotherapy field, either make it smaller than we've been doing previously and perhaps decrease the side effects, or treating other areas which we weren't aware were involved. So they're the only sort of indications at the moment, but it's not standard treatment and it's not funded by Medicare.
Can I just ask one more thing, thanks? I had a DNA done by I think it was University of Sydney, and I'm just wondering, was there any things came out of that at all? Because I haven't heard back from them at all, and it was well over 12 months that it was done. Sorry? Oh, no worries. Oh, right.
There's a
Thanks for that anyway.
Oh yeah, there's a couple glioma studies going on at the moment, looking at was that a blood test or a tumor test that you had?
No, neuron test.
A urine test, okay.
A saliva test
Yeah.
as well.
So I think those are looking at kind of what we call germline DNA, so DNA that's passed down from family to family. There's a large study going on looking at that. These are the sort of studies that unfortunately I don't think you're going to actually end up getting a result specific to you, because I think what they're trying to do is collect a lot of samples over a long period of time and see what happens and see if they can tease out anything. So unfortunately we're not going to know the results of that for a very long time, and it's very unlikely that you would be fed back the individual results.
A quick question for the medical oncology people. Is there any new drugs on the horizon? I've heard that there's a new one out for the autoimmune system, Keytruda. Surely there must be something happening. Thank you.
Yeah, good question, and a question that gets asked a very lot. So Keytruda is in the press with lung cancer, melanoma, bladder cancer, kidney cancer, all those sort of things. By itself, it doesn't do anything to brain tumors. And they're looking, so the current nutmeg trial that Craig talked about is looking at mixing that drug with conventional treatment and seeing if that does anything. I think it's an evolving story, and I honestly don't think that those drugs are going to be that effective based on what I've seen. However, I think there's a new generation of drugs that are coming through with regards to what's going to be worthwhile in the very near future. Craig talked about the Entellence studies and a drug called, I only know it by its old name, which was ABT414. I think that we should have results as to whether it's effective very soon, and I reckon that will be rolled out very soon if it's effective.
So for a patient that's gone through a trial and they've got to the end and they've found out that they've been on the placebo, are they able to request access to that drug at that point in time? And if not, what are the things that are restricting them? Is it a legal thing, or is it the drug company from a cost perspective?
Very good question. And this is an ongoing ethical dilemma for people who design trials. Realistically, most people on a clinical trial shouldn't know if they're on a placebo or not. And that's built into the protocol. Sometimes, and usually people don't know because they can't swap from one side to another. One of the ways we would design trials is to say this drug A is better than nothing or the placebo. And unfortunately, if people who are on placebo then swap to a drug, it can muddy the waters as to whether it's effective or not. That doesn't mean we shouldn't be giving it, and certainly some trials actually build into the protocol the option to swap over, but that's trial specific. And I honestly haven't seen that in brain tumors.
We had a bit of experience with that with an international trial in older patients looking at temozolomide, and this started back in 2007 where temozolomide was only just becoming available and we didn't know whether it was going to cause more problems in older people. And we negotiated with the drug company that patients could cross over once they were off the trial or once any results were clear, but that has to be negotiated, in each trial.
So I suppose just a second part to that question is that because you have to go through the final approvals once you finish the trials, is that a limiting factor that would stop your drug company or the trial organisation from allowing you to? No,
in fact, most of the ethics committees would ask specifically that question. What do you do if you find that the treatment's helpful? How do you manage that with the patients that weren't on that treatment? That's exactly what they would be asking you. So it's not. They'd also insist that you have what's called a data safety monitoring board, who are keeping an eye on the results of the trial. And if it's looking like it's becoming positive, then there are things called early stopping rules where you sort of say, well, this is looking like we're getting a result. We should stop now and offer everyone this treatment.
How do you find out that information?
So a lot of it's buried in 300 pages of trial protocol, but the ethics committee, it's their job to check all of these things, and it's the principal investigators who do the trial, who do all of that. The person who's talking to you about the trial can put you in touch with those people if you wanted to find out.
Thank you.
Please put your hands together for Dr. Lynham and Dr. Fay.
Good to see you.
Busy these specialists are, so we really appreciate you taking a whole morning to be here. We really do appreciate it.